Hello, everyone, and welcome to our Q&A with an expert. My name is Ellen Hosteller, and I am the Chief Science Officer for the John Ritter Foundation for Aortic Health. And today we are being joined by someone that many of you who are joining us today know personally, and many of you got to meet virtually at our last expert webinar last month, and that is Dr. Anthony Estrera, who is a professor of cardiovascular surgery at UTHealth in Houston and Memorial Hermann. And he is an expert in aortic disease and particularly in thoracoabdominal aneurysm repair. Is that correct? Is that your expertise? Okay. And aortic dissection. So he will be answering all of our questions today. I have a bunch that folks have sent in. But briefly, I'd also like to introduce Amy Yazbek, who of course everyone knows, who is our founder and chairman. So hi, Amy, thanks for joining us today.
Hi, everybody. Welcome, welcome, welcome. Dr. Estrera and Ellen are going to be answering and asking questions, and I'm going to be the kid in the back of the classroom going, I'm sorry, raise your hand if you have a question about the question, and then I raise my hand. Didn't have a chance to do that when I was in school. Terrible student, but now that I've kind of made this world where we can all ask questions and be comfortable, I have learned so much, and there's so much more to learn, and you can ask really anything you want. No question is too silly. Here's the first example. Dr. Estrera, Ellen, I've heard it pronounced dissection and dissection. I've had doctors say to me, doctors and other experts, why do you keep saying dissection? It's dissection. It's different than dissection. And the other way around. I don't think it matters as long as you're diagnosed and somebody doesn't say it's a heart attack and accidentally does everything wrong for it. But is there a way we should be aiming for to say it, or do you not care? Sorry, compound question. What is the answer?
In my opinion, Amy, it's tomato. I mean, everyone knows what we're talking about.
Yeah.
I mean, when I was training, actually, we used to get harped on by Dr. DeBakey and Dr. Maddox. They would say dissection as opposed to dissection. But
yeah. all the Bakey folks are the ones that have corrected me, and I don't mean to interrupt you, but I will get ready. It's what I do. Apologize in advance. I digress, as I say, but that's the tattoo. Thank you for saying that, because I think some people, when they're talking to me, they go dissection, and they think of the first time they heard the word, which is when they had to cut open a frog. Dissection, like that. And sometimes I think differentiating how you say it will make a difference, and I don't think it does. I think we just have to be able to say something when we're explaining it to people, and you guys can craft that and we'll do whatever. When somebody says, like, when you cut open a frog, you're like, yes, but the opening is between two layers of the aorta, and that's different. But to be able to like go on what people know, because people do have a hard time with it and sometimes are shy to talk about it because they feel like they're going to pronounce something wrong. Okay, so any way you want to say it, we're in.
Okay. That was a very good note to kick us off on, because yes, I want people to feel comfortable asking whatever questions they have, because probably someone else has one.
Can I interrupt real quick, Amy? I think you're exactly right, because a lot of patients feel uncomfortable about bringing the topic up. And if they're even more uncomfortable because they feel uncomfortable of how to pronounce it, that should not matter. They should feel very comfortable about bringing the topic up, especially if someone's having chest pain in the ER, and they should bring it up. Is this a dissection? Is this a dissection? Just as long as they bring it up and not be intimidated by how to pronounce it. It should not be.
And I have had to, and I'm sure Ellen has too, to like almost empower or embolden people, or almost give them permission to use John's name. Mm-hmm. Like somebody's like, well, what do I say when I go and say that, and if you say that my brother had a dissection and lived, but my mom died or whatever. And they're like, can I just say like the John Ritter thing? It's in my family too. And I'm like, if that's the first thing you want to say, and they're like, what do you mean, falling over a couch? You're like, no, the other John Ritter thing. But I mean, if you need that as an avenue, as an entree to how you want to say it, feel free. Say you're related to me. I don't care. Get it. Right. Okay. Thank you, doctor. That's helpful, because people do feel like, oh, now I'm talking to someone who speaks a different language, to a doctor, to the ER, and it's not. It's all the same thing. Okay, we're good.
Okay, so we had a question from someone who is actually a patient of Dr. Safi's, who, of course, is one of your colleagues, Dr. Estrera, and she, or he, I'm not sure actually, had a type A dissection that was repaired and still has a dissection in the descending portion. And they said that at the time that happened, they said if you need to ever have this repaired, there's a very high risk of bad outcomes from this surgery. But they're wondering if this has changed in the 20 years since that they were given this advice. What are the risks of that surgery? Is it a bigger deal than having the sternotomy that so many people have with the type A? Since this is one of your areas of expertise, we'd love to just hear a little bit more about.
That's a very good question, and it comes up quite often because, once you have a dissection, that dissection flap will go all the way downstream from the ascending to the thoracoabdominal aorta and puts everything at risk for enlargement and further complications. There's no question that the operation to perform for that situation is a very large operation that has a potential, risk. Now, I'll admit, now compared to 20, 30 years ago, those risks have been mitigated by a lot of the techniques that we utilize, specifically paraplegia. Paralysis from the waist down was one of the worst, is a horrible complication to occur, but was as high as 20, 30, 40%, as recently as the 1980s and even into the 90s. But with a lot of the work that, pioneered by Dr. Safi, a couple decades ago, and having worked with him for, over 20 years, we've been able to reduce that risk really down into the single digits, 2, 3, 4%. It's still not zero. So that's why there's still a risk. And then another complication we're concerned about is the risk for requiring dialysis, renal dysfunction. And that could be as high as, 10, 15%, but that's fortunately not permanent. That's usually a temporary situation. And usually you recover your kidneys within a couple of months after the operation. But you're exactly right. A very large operation, a very huge insult. But I'll tell you, the other advances are really utilizing some of the endovascular techniques. As patients get older, and are at higher risk for undergoing an open repair, then there are hybrid and or complete endovascular techniques that are being perfected across the country that actually have very good results in terms of mortality and paraplegia and renal dysfunction. It's just a lot less of an insult to put a now. The stent grafts in general have to be followed more closely because these situations do have a higher re-intervention rate. But fortunately, the re-interventions that are required can usually be performed with catheters and not have to open the patient up. But still, close follow-up is still required, despite that.
I'm so glad you mentioned follow-up, because that segs nicely into our next, which is, who should you follow up with if you've had surgery for dissection or even an aneurysm repair? People feel like should they be going to a vascular surgeon every year? Should they be going to their cardiologist only? Is there someone you recommend that's better than the other? Is there a whole team? Should they be hitting all of the specialists on a circuit every year, or what? Because I think practically speaking, people aren't just sure who they should go to. And we hear from a lot of folks who say, I know I was supposed to do XYZ, but I didn't know what to do. And so now it's been 3 years or 4 years and I'm scared.
Yeah, that unfortunately happens too often. And there's actually been some recent papers, literature, scientific data that suggests that many patients who have had aortic dissection will be lost to follow-up. As many as 80% don't get the expected protocolized imaging surveillance program that they should get. So this is where it's important to try to increase the awareness of the fact that you do need to get imaging if you've had an aortic dissection at some point. Now, it'll vary depending on the situation, and some may say annually, some may say every 2 to 3 years. I know John Leftiadis had mentioned every 2 to 3 years. I don't think that's unreasonable, just as long as you get followed up. Who to follow up will really depend, in my opinion, who you feel most comfortable with, but who also has the knowledge base, or at least access to the knowledge and of aortic disease management. So if it's your cardiologist who feels very comfortable about managing this and also has someone that they can go to ask questions, then that's perfectly fine. Or is it your vascular surgeon? That's perfectly fine. Or your cardiac surgeon, that's fine. I tend to follow up a lot of patients, and I'm willing to see all the patients that come on a regular basis. But that's just because that's what I've been doing for 20 years. I think as a patient, you just have to feel comfortable with the person you're following up with, and also make sure that they have some interest in aortic disease management. If they don't, then they need to go somewhere to where they do have interest in it.
But I think that's a part that's missing in a lot. And because you said that, I know you say that to your patients under your care. It's so difficult for the likes of, well, I can't give medical advice, but for me to go tell someone to tell their doctor this, and this, and then they come back and they're like, oh, they said that, I mean, literally, we had this happen to somebody. They said, no, I'm too young for that to happen to me. It's like, no, it already happened to you. Well, that was a fluke, and then that was out, and that's fixed. I'm like, who is saying this to you? And I feel bad. Well, I don't feel bad speaking over their doctor, but putting people into the situation where they are having to, I'm not saying medically educate, or am I, their cardiologist or their, vascular person. Is it okay for us to say, because if there's a disconnect between, not everybody has you, Dr. Estrera, that are like kind of following and saying, oh, who did you talk to? And would you like me to send them more information? Like helping their doctor be interested in it. Do you know what I'm saying? Sometimes people are cut loose for whatever reason, especially family members who haven't had the surgery. So to some people, it doesn't look like it's an urgent thing, or that it should be front of mind. I feel like it should be on the front. You open their file, front page. This is what's happening. And in the thing when in Ellen's former job, and that we know at the John Ritter research program, I mean, I print things out for people. So and I'm like, tell your doctor, put this in your file. They're like, well, it's all online now. I'm like, John Ritter Foundation for Aortic Health, John Ritter research program in aortic and vascular diseases, because it catches people's attention. But how do you talk to your doctor if you've operated on me and I'm supposed to go and follow up, and you have explained, which doesn't always happen, beautifully why I need the follow-up, then it's on me to go to a doctor and explain that. Until everybody has the same information, what's the best way for the patient to bring all of it to their doctor?
I think, you said it earlier, Amy, you have to be your own best advocate, unfortunately.
So you put doctors and patients on an interesting power dynamic, and this. It's sometimes hard. Forget the way I was raised, a woman speaking to a doctor, especially if it's a man. I mean, it's terrible, but that's still kind of a thing. Is there a place to go? Is it okay to say, can you just send somebody a link to John Ritter Foundation and say, doctor, could you just watch this? I'd love to still be your patient, or whatever. I don't know. How do we make people pay attention?
Yeah, I think, it's a very complicated question that has multiple layers to it. But what I would say is, your organization, the John Ritter Foundation, could be one of those connector type situations that can
Yeah, we want to
be that bridge. And the patient can say, well, I read this on the John Ritter Foundation that's been supported by all these folks. What do you think about this, doctor? I mean, it has to start somewhere, you know?
I know. It sucks to me that there'll be a day because, again, a lot of the layperson doctor dynamic is what and hopefully is changing as a woman talking to men, where you have to go, I know you already know this, but, and then lay the information in, like, not to, do you know what I mean? It's like kind of a power thing. I hope it'll change someday and everybody realizes they can learn something, like a doctor or a cardiologist would be curious about this thing. And every patient they have, they know they're going to learn from this, right? For the next patient. So anything you want to help us with, or any doctor wants to tell us how they would, not like cardiologists and aftercare doctors, what's the best way to receive the information, and what would make an impact? Anything we can do towards that? Anybody out there know anything? Like even a survey, what would be the best way for you to understand? Is it a packet? Is it a link? Is it whatever, without ruffling your fancy feathers, sorry, but being able to get like the right information, because I know that it breaks down in follow-up, and I've seen that with disastrous results. And okay, I'm going to say this, then I know there's tons to do, but the words that doctors use, especially vascular, the word downstream, which can mean literally downstream, up and downstream of where your injury, your insult is to where it happens, but also downstream meaning over time. To explain to people without diminishing their hope, there is a risk for this happening again, and now it's on to you and to help yourself and your family. Okay, I'm out. That's too much of my time, and I concede my time. Thank you. I just love you, Tony, Dr. Estrera.
We always appreciate your comments. And I think that's something we can brainstorm and talk about as an organization and with other clinicians about how do you want to receive that info. And I know, hearing from a lot of people and hearing from clinicians who reach out to us, especially when I work with Dr. Milowitz, a lot of people do want to learn and know more and to care for their patients in the best way. So there's definitely an appetite for that out there. And hopefully we can have some of these resources for
doctor facing.
Sure. Yeah, exactly. On the website, so they can use these tools to provide better care for their patients, which almost all of them surely want to do, of course.
Because, absolutely. But you don't know until you know.
Clinicians.
You don't know until you know. It has to do with your own history, but it also has to do with doctors and people who are going to be doing that after follow-up forever and ever. Didn't mean to call it aftercare. You know what I mean? Like follow-up downstream over time. They don't know until they know, and they don't want to learn the hard way either. Everybody has the best intentions. Okay, Dr. Estrera, you and I will be talking about this.
Okay, we have some questions in the chat. Both of them are a little bit detailed, but I figure why not go for it. So someone is mentioning here, and I think they're going back to the very first webinar we had with Dr. Eleftheriades, and he talked about the balance of aortic disease and then coronary artery disease or atherosclerosis. And in his talk, he mentioned that it was rare to see both of those things happening in the same person. And this person here is saying they have both a thoracic aortic aneurysm and high CAC score, which I believe is the calcium score for the coronary arteries. So is that something that you have seen before? Do you think this is rare? Any thoughts?
I mean, Dr. Eleftheriades, has published a couple papers related to the fact that having atherosclerosis or having an aneurysm may protect you against atherosclerosis. And that's statistics. Okay, that's statistics. But remember, there's always a possibility that, people can fall out of statistical, norms. And I have seen patients who have aneurysms and we do coronary bypass on. I mean, we do that. It's not common, but it can happen. So to answer, the question, is it possible? Yes, it's possible. It's not common. I agree with Eleftheriades that is it really protective? that's a very strong term in my mind, that it's protective. I'm not certain it's protective, but it's not as commonly associated with aneurysms as other conditions, so to speak. So the bottom line is it can happen.
Okay. Okay, and then we have a question here that I think relates to when you were talking about possible side effects after thoracoabdominal surgery with a kidney. And this person, I think, has chronic kidney disease. So is this something that it means that we can't do that surgery in that population, or that perhaps endovascular or other approach would be more appropriate for those patients?
Yeah, that's a good point. And when we're talking about risk factors for descending and thoracoabdominal aneurysm repair, with or without chronic dissection, chronic kidney disease is a harbinger for higher mortality and higher morbidity after open repair. It's also associated with higher risk after endovascular treatments. But when we looked at our work and trying to delineate which patients we should potentially lean more towards doing an endovascular treatment on, patients with chronic kidney disease, patients over 70, and patients with chronic obstructive pulmonary disease were the three strongest factors that patients who had endo did a little bit better than open. So we're getting more information as we do more cases. We're better at defining which procedure or treatment is better for a specific patient. Every patient needs to be individualized, though. There's no question about that. And obviously, younger patients who have a much longer life expectancy will err on doing an open repair because it's just more durable than an endo. But a patient who's maybe a little bit older with chronic kidney disease, and if it can be done safely with endo and they have the right anatomy, then I would err more towards an endovascular procedure.
Quick question. When you're talking about kidney disease, of which I know absolutely nothing, so naive question here, but I'm curious. You're talking about a pre-existing condition. Is it possible to trigger a kidney dysfunction, maybe not disease, because of just of like the occlusion because wouldn't it be, is it like the blood perfusion, the right word, perfusion to the kidneys? Is that something that can get can be disturbed during that surgery?
Yeah.
And that's why, is it, because you're not feeding it the blood, the oxygen?
Yeah, that's exactly right, Amy. When we do these operations, depending on what part of the aorta is involved, you can affect the blood flow to the kidney, thus stressing that kidney. Now, a kidney that doesn't have any dysfunction, which is can recover quickly, but a kidney that has been affected by diabetes and hypertension for 40 years can be affected. Now, remember, I mean, I appreciate you bringing that up, Amy, because we think on medical terms, and not everyone on the chat and then listening to this webinar has the same expertise, so to speak. So it's not, when I say chronic kidney disease, that's a general term that tells you about how functional, how strong your kidney is in doing what it's supposed to do, which is filtering the blood and creating and getting rid of fluid or making urine. So I actually have what we would say chronic kidney disease down to about, up to about 70 to 80% dysfunction, but yet never need dialysis. So another concept, because as a patient, all you care about is, do I need to be on dialysis or not? So there are degrees of kidney disease that are, these tests can demonstrate that you have a little bit of disease, and that's why it's important to know that, because that will help us risk stratify someone for an operation.
So there's almost like a score stratification of how I've seen that with like risk, right? With other like surgeries, like you're this age, but you're this, like with when somebody breaks their hip or have some other osteoporotic situation. I don't even know if that's a word, but where it's like bone and bone density, and they're of a certain age, and you're like, but the operation would be like them, might fix the thing, but to their body, who doesn't know we're doing a beautiful thing here that's helping you, it would feel like they got hit by a car, and it might stress them out even more. So every situation, I get it. And so our what's the word for kidney stuff?
Renal?
Yeah, renal. What's the word for kidney stuff? So are renal diagnostic tests done before every, even if you're having an ascending or a type A done because of downstream issues, all of those things are stratified with the risk of the surgery. Okay, good.
The routine lab will pick up your creatinine, which is a blood level of that tells you how good your kidneys are functioning.
Okay, so all those tests you have before you have any kind of surgery are indicating to the surgeon what would be the best type of surgery, best for your recovery, and what might be off the table for you.
That's correct.
Okay, thank you. Thank you.
Well, let's continue on our descending questions then. What are some of the signs that maybe someone with a dissection or descending does need to have it repaired? We know that there's never a magic number for anyone and everyone's different, but is it size, other things that you can see on that imaging that make you think we need to repair this either endovascularly or with an open surgery, symptoms people have, anything else that I might be missing?
Yeah, no, I think you hit the big ones. And, whether it's fortunate or unfortunate, the reality is size matters in aortic disease management. And
hold on. I'm going to need a pencil to sign off on that. Okay, because I don't believe it.
No,
okay.
No, but the diameter of the aorta is important. Okay. Unfortunately, it's not, it's not necessarily the best indicator, and Dr. Liftaudis and I are having a little debate at the symposium on Friday, where we're talking about whether to do things at a smaller diameter or keep the guidelines the same. Regardless, that is probably the most, definitive metric measurement that we use that helps us decide whether to move towards an operation or not. I think.
Do both of you have body mass index in your?
Yes.
So you're both arguing different sides of it?
Actually, height too. So the shorter, actually height. He showed some nice data that height may be more. Is equivalent to body mass, or not body mass, body surface area, and so body surface area. So height is probably just is equivalent to determining that risk. But
I think he was trying those out on me. If you want any hints, I'll tell you what he's going to say.
Illegal coaching.
But this is exactly where it comes from.
Yeah.
This is how you learn from other doctors and from patients. Of seeing their experience, because even though you have operated on thousands and he has operated on thousands, they're not the same thousands.
Right.
So for you being able to have give his experiences, and then you mix Diana in there with all of it, the overall, this is where the answers come from. But do we get to bet on this? Like who's going to win?
Well, I don't know. I don't know how they judge it. So. Yeah.
Careful, somebody might replace you last minute like the Derby. I'm going to just really quick get my calculator out.
But Ellen, size, symptoms, and then those are traditionally the main factors that help you decide whether to do an operation. But other factors that we have been made aware about, really through the work of Dr. Diana Milowitz, is this genetic component, which becomes very important. I like John's analogy to grains of sand on a beach, and just having one grain be off that can lead to an aneurysm, and he's right in that regard. But it takes we just need many more cases to help us determine what those patterns of disease are with regards to genetics. But having said all that, 20% of the cases of thoracic aneurysms and dissection do have a genetic predisposition. So 1 in 5 that we know of right now. So if someone has a genetic predisposition of some type, that might push me to be more aggressive at a smaller diameter. And something we don't really talk about too much is the anxiety caused by the aneurysm.
Mm-hmm.
And I always describe to my patients from that aspect, you're either at one end of the spectrum or the other. So one end will be that rancher who lives in East Texas, out in the woods, and he's a guy who's 75 who says, "Doc, I have this 5.5 centimeter aneurysm. It's not causing me a problem. When it's my time, it's my time. I'm fine with that." Versus the person who is on the other end of the spectrum, and I have my 5.0 centimeter aneurysm. I am so fearful. I can't sleep at nighttime because I'm so worried about that. That person, I would err on doing something sooner because their life is horrible right now.
And their blood pressure from that stress could will absolutely, in my opinion, from what I've seen, exacerbate the situation, and just the higher what would it be? Adrenaline and whatever the other one is, norepinephrine. What do you call it?
Epinephrine, basically. Yeah, epinephrine.
Which is
Norepinephrine is fabulous. I love that.
I call it norepinephrine because I can't remember the name of it. But as long as that flippin' rancher out there doesn't try to mansplain to his family that, hey, this is a thing that happens and it falls out of the sky, as long as all of the people around whoever that rancher, and she may be a woman, knows that what they're seeing, the choice that their loved one is making and that the doctor's making for them, doesn't necessarily impact. They might have a relative with the same kind of condition, maybe even the same numbers, and it would be a different diagnosis in terms of what the medical interventions would be between them and their doctor.
Mm-hmm.
Just because your uncle or your brother is doing it this way, that doesn't mean that you can't take a more proactive thing, and that your relationship with your doctor and your surgeon, you can make your own decision. Because a lot of people are like proud of like, yep, grandpa was like, screw it, I don't care. And it's like, great, you have kids now, get on it.
Well, I think what Dr. Estrera said earlier about treating everyone as an individual is really applicable there.
Inside of families, though.
Not only is it your physical factors, but also things like how much anxiety you are, your kids, your job, all those things go.
Or a person who can get pregnant and have a baby.
Absolutely.
You still have the genetic load that maybe a man in your family lived a long time with it and never had that hemodynamic pressure of having a baby, or the hormones and what that does, and just makes you like a more vascular person. I feel like I'm saying words that I don't know what I'm talking about, and I don't want to be like, but I know I'm not a doctor. I know I'm not a smarty pants.
No.
Well, I'm a smarty pants. That's what I am. But this means so much to me that you guys are doing this, because people hear crazy stuff or half the story, and they come and talk to me, and I don't want them to have to hear it from me, because I want to be able to turn them over to you, hence turning off my mic.
Well, one thing I will just emphasize with that is I think it's really important for us as members of the community, when we're online, we're on Facebook talking to our friends and family, that we remember that we are all individuals, and just because something is true for us and our conversations with our clinicians, we should not be necessarily giving that advice to others, because you never know someone's medical background and all of that. And I know those questions get asked on Facebook all the time because people are looking for answers. So I understand the impulse, but having those conversations with your clinician is a much better idea than asking.
And Ellen, that's why Mended Hearts is wonderful. Yes. Because they support the way peer-to-peer and post-surgery people take care of each other, and I have never heard of any case where they're like, this is what you should do, this is how I did it. Mm-hmm. It's all about helping the person and the family have a conversation with their medical.
And advocate for themselves, as we discussed.
Advocate for themselves, okay.
Yeah. Okay, back to my list. What do we got here? Okay, so imaging, MRI, CT, CTA, MRA, what are all these different letters? Which one is the best gold standard? Does it matter? You know, echocardiograms are in here, which of course our cardiologists love. Some people I know have concerns about the radiation, but then I've also heard that today with modern technique that's a little bit less of a concern. So can you just speak a little bit? I know that's a very broad question, but
yeah. I'll also just refer one more indication, which has been mentioned in the chat, which is absolutely correct, is rate of growth on an annual or 6-month basis. And the guidelines in the past have always talked about 4 to 5 millimeters of growth as being significant. And I don't disagree with that. That means that something's changing. And this gets to the imaging too, because, you know, there's a lot of different ways to image the aorta. And I think what's really important in my mind is when I assess someone, I actually have the raw information so I can review it myself. It's not unusual for a radiologist to just, you know, write or make a comment about a certain dimension or something without any clarifying information related to that. Now, what do I mean by that? Let's take, for example, CAT scans. Depending on the angle, and we talked a little bit about this before, about the sausage, and if you cut it at an angle, then it'll be more oblique. And Dr. Leftatis talks about obliquity regarding, you know, that angle of how it's cut. And when we're talking about dimensions, we're talking about transverse, we call center line, double oblique measurement, so that we can truly see what the diameter is. And so, you know, that's one aspect. Another aspect, depending on the imaging, which could be either with the with the MRI or the CAT scan, is really the phase of when the study was done. Remember, you'll hear the term gated imaging. Gated imaging is when the actual images are coordinated with the beating heart, so that you can get it and capture the images on the same phase of the beating heart. Because if you imagine the heart's beating, these aortas are elastic to a certain degree. So when the heart compresses, the aorta can expand a little bit. Is that an aneurysm? Probably not. It's just the normal diameters of the aorta. But that's why I think 1 to 2 millimeters is really not a big issue in my mind. If you have an image at 6 months later and it's 1 to 2 millimeters wider, I don't worry about that as much, because that's probably within the standard error for that imaging technique. That assumes, though, that, let's say it was gated and that it was recorded to occur in diastole. Diastole is a phase of the heart. So depending on what phase of the heart, just as long as that's consistent and documented, you know, that's all that really matters. And then you can interpret the results. Radiology don't really necessarily do that, to be honest with you. And we need to keep pushing them to have more consistency on how they report these images. But whether it's MRI or CAT scan or even echo, you know, especially MRI and CAT scans, I personally just reread everything so that I'm comfortable about what I'm seeing. And I think they're both, especially nowadays, they're both pretty good. So again, the MRI does not require contrast. The CAT scan requires contrast, but the MRI takes longer to acquire the images. So you may be sitting in the donut for an hour, 45 minutes, versus the CAT scan, which is literally just, you know, probably 30 seconds to a couple minutes. And then the echo requires you to have a good technician that actually uses the ultrasound probe with the cold lubricant they'll put on your chest and take pictures of your heart. And then that's where, you know, that has to be reported properly in terms of how you measure it. So there are a lot of nuances on this, and it becomes very important that your physician, you know, understands how these images were acquired when those reports were written, because there could be some variations.
Mm-hmm. That's fascinating. Amy, I couldn't tell if you wanted to. No? Oh, you're muted, ma'am.
No, I was just looking at people in the chat at the same time because of my ADHD. But I can also listen at the same time. So I was, and it's interesting hearing what you're talking about and people like in real time responding to that. Oh, how I wish we could be in an actual giant room together at some point too.
Yeah.
You could see these people and these faces. Shall we plan a symposium at some point, guys? I mean, I show up at them, we all show up at them, but boy, I would love all these people we're talking to for us to be able to have them in a room and online at the same time. This is really huge, Dr. Estrera. Thank you so much.
Someone in the chat talked about, in terms of other indications, asked about family history. And I think this one is tough. So I'm interested to hear what you say as the surgeon, whether you would take that into account, especially if it's something like we don't know the diameter someone dissected at. Perhaps we just know that a sibling had died of a dissection in the past.
At a certain age too, which is interesting.
Yeah, and age, or is that information to know they're at risk, but not necessarily information that feeds into timing of surgery?
No, it's very important to know information. I mean, I just saw a patient today whose family member, actually, I think it was father, died at the age that he is currently. And although his aorta is about just over 5 centimeters, because he had a history of family history of acute type A dissection, I think that in and of itself makes me very concerned. And a risk factor for dissection. And so he's going to be seen by Dr. Milowitz's team, and then we're planning on doing a repair on him for that exact reason. So I think age, the more information you can have about your family, gives the physicians a lot more information to work on. So
this Dr. Estrera, this with Tommy Ritter, my brother-in-law, John's brother, happened at 2 very critical points. One was right after John died, and all of the kids and Tom first-degree relatives had echocardiograms. And I think I've told the story a million times, but please listen. Tom Ritter went in. This was months after John died, and he's like, hey, I didn't even have to take my shirt all the way off. I'm like, you didn't get the right thing. And they did his just abdominal. And I said, you tell them you're John Ritter's little bit older brother, plus you have cerebral palsy, and you don't know how that is going to impact because of blood and And he's like, no, they seem to know what they wanted to do. So he went back. So because of the family history, they scanned the wrong part of his, not the wrong, but not the entire aorta, which they should have. He got sent back by strong arm sister-in-law and had it scanned. And then over the years, had the scans, like we said. And then when he did turn up with an aortic aneurysm ascending exact same place as John's, the original team or their original idea was, oh, it's not big enough to operate yet, to which Diana had to say his brother died at 7 years younger than this, because that's how many years had gone on. We don't know how fast John's grew, but also knowing that the age, and especially in a family of siblings, can be indicative of this particular gene mutation that is causing this problem that we haven't named yet, but we can talk about the symptoms of it. We can call it do you know what I mean? So I think age is a huge thing. And then especially if someone has given birth, and that is something that either triggered or exacerbated it, like all those case histories of people in their family. I know you look very closely at that, Dr. Eleftheriades, but sometimes if they're not with Dr. Milowitz's thing, or Eleftheriades, called you the wrong name, Estrera, sorry. You know who I'm thinking of. But I mean, I've talked to him about this too, because you are connected to Dr. Milowitz. Not everybody is connected in that way. I would love to have like one piece of writing that's not a scholarly paper, but maybe culled from a scholarly paper. That's one thing on our website that just talks about that, even though you don't know the name of your gene, like people we know, or how to call it, or how to look it up. You should have on you the times how old your person was when they passed away, just like they do for breast cancer. It's like if your mom died in her 30s, it's different than if your mom died from breast cancer in her 80s. Okay, and that's my story.
Fabulous. Okay. All right, so this is a little in a different area here, and I don't know if you have knowledge you can share on this, but someone mentioned that they had their dissection 1 month after having their COVID vaccine shot. And they said the doctor said it was not related, but I always wondered. And then someone else in the chat has also asked about this relationship due to death after the vaccine. So I'm not aware of anything published in your research that indicates that this creates a risk for this, but I would love to hear if you know of anything, Dr. Estrera.
Yeah, I think I'm not aware of any studies that suggest that taking the COVID vaccine increases your risk of dissection. The thing about COVID is what we're learning about COVID and its cardiovascular manifestations is probably more at a smaller vessel, situation as opposed to a large vessel inflammatory process. And so, having said that, you don't really know until you do the studies, but there hasn't been any signals to suggest that that the COVID vaccine has any significant relationship right now to acute aortic dissection.
What about COVID itself? What about the infection of COVID itself?
Yeah,
not the vaccine.
Not. I mean, there's so many people that have gotten COVID, and remember the incidence of dissection, depending on your age, ranges between 7 to 15 per 100,000. So there are always going to be, people having dissections with or without COVID.
Right.
So there's nothing that I've seen and that I've seen recently that suggests that increases your risk for dissection in general.
Okay.
So I don't want to discourage people though from getting the vaccine if you haven't had the vaccine. I think there's a lot more upside to getting a vaccine and protecting yourself from significant illness and hospitalization with a vaccine. And obviously, if we hear something and there's something that comes out, then we'll obviously let you know, Amy and Ellen, regarding this topic. But nothing comes out. I haven't seen anything recently, on this topic.
With large numbers, or that would actually prove an indication?
That's exactly right. Yeah.
Okay. All right.
And I'll just add that the Marfan Foundation, which their website is marfan.org, does have a statement from their professional advisory board that does recommend the COVID vaccine for their patients. So go check that out if you want more information about why they're making that recommendation. It's not just specifically for patients with Marfan. I know a lot of people in this chat probably don't have that particular syndrome, but read through their materials on that, because they have a lot of extensive research where they've looked into the risk balance, and I believe they have endorsed it for all of their patients, including children. Okay, what else do we have? Okay, so let's see. Going back to my list here. Okay, so I know you're a surgical expert, not genetics, but we have a few genetics, and I know you are very well informed on that too. The easiest question here is, if you have a family history, who should you see about that? Is there someone who can recommend testing for you? How do you find your Dr. Diana Milowitz? And I think the answer here for a lot of folks is going to be looking online and asking for resources. But if you're a patient who just had a dissection, maybe, and you're not in Houston where you have that available to you, is there anything you could tell people about how to find someone in their community to talk to about their family history? Or do they need to talk about it? I guess we've already kind of covered it, but just to reinforce how important it is.
Yeah, I think, I'm not aware of all the differing resources depending on location for access to genetic counseling. I just know of, we're fortunate here in Houston to have a lot of opportunity, a lot of resources in this area. But if you're in, wherever USA and you have a dissection, that's a that's an important question that you need to ask your doctor. Was this genetic? And if you don't know, is it okay to refer me to someone who may know in your local area? You know, one thing about COVID too, with regards to resources, we've all learned how to do things virtually. We're doing it right now. And I'll tell you, a lot of my practice, at least the new consultations that come from far distances, we do virtual visits. And although, I personally don't have a license to practice outside the state of Texas, you can actually provide, you can still do a telemedicine visit and have a conversation with a patient and send your recommendations to their physician. So whether it's in Houston or Michigan or San Francisco or Cleveland or New York, wherever, I know there's a lot of good resources for genetic counseling in those areas, and that ask your local physician, your doctor taking care of you, do I need to be checked out by a genetic counselor? And if so, who would you recommend? And then that brings up Diana, for the foundation, maybe listing a number of resources or names of for your patients to look up, in every state.
Yeah.
That might be a good resource for the folks that come to your website. Just an idea, but that's what I would say, Ellen.
Yeah.
Can I say something real quick? So, when you go for a genetic thing, I had a family member, nothing to do with aortic dissection or anything, but had the surgery for the, what is it called, doctor? The pectus something, like the teenage
pectus excavatum.
Right.
Yeah.
Excavatum. Right. Which is like a misshaping or like a growing together, I don't know what adhesion. I don't know, something like that. Whatever it is, the kid then, young girl, they wanted to do a panel, an aortopathy, possible genetic panel, because that can be associated with some syndromic stuff. And when she went into the thing and they didn't understand what this was, they gatekeep, kind of, not gatekeep, who is going to get the actual like swab or blood or however they do it. I think they just swab it. But the first test is the Marfan test. And if you don't have those outward syndromic things, they're like, well, we're not too worried about this. You don't meet the criteria for getting the rest of the genetic stuff. And I hate that. And I don't know if that's a real thing and everybody's doing it. But the idea is you don't have to have a syndromic thing, something that shows up in your physicality. Your uvula doesn't have to be like this, or your eyes don't, to be completely at risk for this. Absolutely. And it's better to be in that study anyway. And so I kind of tried to push this. I mean, like joint, and this kid has loose, I'm sorry if I'm telling your story out here, I'm not saying your name, kind of loose joints and stuff. And I don't want them to have any kind of aortic problem, but the fact that it was swiped, what is left or right where you don't like it, you kids with your abs, but that it was like, no, we're not going any further with this because your thumb doesn't completely blah, blah, blah. Yeah. There's got to be more of a criteria, less of a criteria or whatever, that only people who have outward signs of this can get tested. And sometimes there's outward signs that go for both several things, like loose joints and the elasticity and the thin.
Absolutely.
So
I'll just add one because I think that is a great point, Amy, and we are getting better at it, I think, in the genetics community. And as Dr. Estrera said, and some silver linings of COVID have been, improving how we can do things remotely. And there are companies today that do offer, at least in the United States, and I believe in Canada, what we would call direct-to-consumer genetic testing. And this is very different than something like Ancestry or 23andMe, which are not clinical care.
Although I've done them all, but
disclaimer, we have no interest in these companies, but the two that I'm aware of are called Invitae and Color, and both of those are remotely done. So, I'm sorry?
What was the second one you said?
It's Color, as in the color green.
Genomics?
Yeah, just the word color.
I knew them. I'm going to call them.
So both of these companies can send something to your home and do genetic counseling over a virtual network.
So you do it without genetic counseling.
Yes, absolutely. And they make their genetic counselors get licensed in every single state. Truly, these people are walking around with 50 licensures. It's a wild way to have to manage things, but that's what the rules are.
I didn't realize Color was doing that because they.
Yeah, so look into those two companies, decide if it's right for you, of course. They are not affiliated at all with the John Ritter Foundation, just as a disclaimer, and they do charge. It is a fee-based system, although at least with Invitae, I know that they can bill your insurance. So
more information on that. Can we work on that? Okay.
And we'll learn more in the future when we have our genetics professionals do these. So, well, we have Dr. Estrera here. I won't bore him more with genetics questions.
He loves it. He told me he loves it.
I know. He's the best because he knows all the genetics and the surgical things. We have someone asking about, is it a good idea to take aspirin after surgery? Is that something that's recommended? We hear that a lot for general health recommendations, especially for some older people.
I think if your doctor recommends you to take aspirin for cardiovascular disease or anything like that, take the aspirin. It's not detrimental to your dissection. When I do a repair and have done a Dacron graft open repair, I do recommend patients to take aspirin for about 6 weeks just to, and there's no data to support this, but there's a lot of raw surface of Dacron in there, and in my mind, it doesn't hurt to have a baby aspirin on board to just allow the platelets to not necessarily congregate on that new graft that I've just placed. But again, there's no data to support that. I'm just doing that as my sort of preference as how I treat the patients. But no, I don't think there's any detrimental effects for taking, a baby aspirin if one's had an aortic dissection in the past in general.
Doctor, is it different if your opinion about aspirin? Is it different if you've had a mechanical valve or a biological Calpig situation?
Yes.
Because coumadin does its own thing, right?
Yes, absolutely. So that's an important point. And I think Bill asked about baby aspirin. Yeah, once per day is what I recommend. But having said that, your question relates to if now the valve is replaced. If the aortic valve or any valve is replaced with a mechanical prosthesis, then you're going to need Coumadin. You're going to need anticoagulation with Coumadin, warfarin. And that has to be managed very closely by your doctor to make sure you're at the right levels depending on what kind of valve was placed and what location the valve was placed versus a bioprosthetic valve. And those can either be porcine or pericardial bovine. And those kind of valves, what we call tissue valves. The data and recommendations have always requested you to be on anticoagulation Coumadin for about 3 months. But most physicians, most surgeons will just require their patients to take a baby aspirin once a day. I mean, that's the reality, because there are some risk and benefits that you have to sort of weigh with regards to anticoagulation. And if someone already has atrial fibrillation or has higher risk for blood clot, then I'll err putting them on anticoagulation versus a young, healthy person who will tolerate probably just a baby aspirin and be fine.
And just in case, just stepping back, one thing, there was a time, I'm sure, when all of us, not you, but didn't know what anticoagulation. So what we're talking about with a baby aspirin, which seems like that's an aspirin for babies, but historically, now going back a little bit, people would take that as an over-the-counter version of an anticoagulant because it has an anticoagulant effect. That's not what its main thing is for. It's baby aspirin. But so you're saying it's to make the platelets less likely to jam up together, and they might stick to the surface of something that wasn't in there formally. So to be able to in the blood so it flows better and doesn't, what would you say, make a internal kind of like scab, right?
Right. Cause a thrombus or a clot to form. But again, I can't say there's any data to support that. I just do that. But you're right, the distinction with anticoagulation versus antiplatelet therapy. And they're really two different things. But
right, well, because of fibrinogen, right, which is the kind of things like when beavers make a dam and they just put this stick and then this stick and this stick. And so that's like the little sticks that are in your blood. And it's not the sticks that make the problem. It's then the platelets get stuck in it.
That's pretty good, Amy. Right? I'm impressed.
I'm very, very good at
very impressive.
Remember how. Well, let's make a movie.
We've come up on an hour, so we have to let Dr. Estrera get back to his work, but we're grateful for him and his time today and earlier this month joining us to share his knowledge to our community. There's people in the chat thanking you, saying that they're your patients too, and they love you. And we also saw many messages on Facebook saying, oh, he saved my life. He's been inside my chest. My family is so thankful for him. So we know we have a lot of fans of yours in our community, and we can't thank you enough for sharing your time and expertise with us today.
Okay, thank you very much. Thank you, everybody. And
thanks, Amy, for joining us as always as our fearless leader.
I don't know what I am. Thank you.
Thank you, Amy. Thank you.
Take care.
Bye-bye.
Bye, Tony. I'll talk to you.
Bye-bye.